Great. Okay, so I was charged with reviewing the data that we published from the real-world HLH study in the use of Emapalumab in MAS. So I don't need to explain this to this crowd. And actually, let me just apologize in advance. I have a lot of other duties I have to get to this meeting, so I'm literally like running out of this room at 10:20. Not because I don't want to be here, but I just have to be at other places. But at least for the time that I'm here, we can discuss this topic. I don't need to belabor these points. We all know what systemic J is and MAS is. We're going to focus this talk on data that we have on the use of the drug Emapalumab, which neutralizes interferon gamma, for which there's a lot of data in animal models, in human settings, in its relationship to MAS, and in MAS in particular, secondary to systemic JAA. And we are fortunate to have a FDA indication for Emapalumab in refractory primary HLH, the sort of cousin of MAS that is usually associated with a genetic diagnosis. And because the drug has a label, then physicians just to get the sort of right orders and then develop real-world experience in using that drug in other conditions. So the real HLH study, and I should say, acknowledge that there's probably really nothing more real world than the 4 stories we just heard a few minutes ago. And I think it's important that we tell those stories, because to me, it's those stories that that drive what I do, and I hope that regulators get to hear those stories and get to think about that and help them drive what they do. But in the setting of this study, what was done was a retrospective chart review of patients that received Emapalumab in the United States across 33 U.S. hospitals. And this was the real-world use of Emapalumab in all settings. So we have real-world use of Emapalumab in primary HLH. We have real-use world of Emapalumab in macrophage activation syndrome. We have real-world use of Emapalumab in other settings. The data I'm going to present to you focus solely on the subset of patients in which it was used for an indication of macrophage activation syndrome. So you can see the details of the study here. As I said, it was a retrospective chart review that had an epoch spanning the course of about 3 years. Data were extracted onto standardized forms with a number of outcomes being focused on in the analysis. Just to sort of show you the cohort of patients with Still's disease, we only had 10 patients that came out of all the charts that were reviewed that had Still's disease that received Emapalumab. And they look a lot like all these same statistics and demographics and patient characteristics of patients that had MAS and Still's disease. So these were sick patients, many of them on ventilator or dialysis or other organ support, many of them in the ICU. And they meet laboratory criteria, all right? So they have elevated ferritins, they are thrombocytopenic, they have liver dysfunction, they're consuming fibrinogen. They have the biomarkers of interferon gamma with an elevated CXCL9, and those in which it was measured. You can see that the denominators change because, again, this is just retrospective chart data, right? No one was enforced to do anything in this study. And patients were obviously received a lot of medicines prior to the initiation of Emapalumab. These ranged from glucocorticoids to anakinra to cyclosporin, and for Paul, indeed, even one patient that received etoposide. And then many of these medications were continued while Emapalumab was administered. So Emapalumab was actually additive therapy in many of these cases. Again, you can see the range of things that were used during Emapalumab therapy. It's all the usual suspects. And the reason for initiation was, was either refractory disease, recurrent disease, or progressive disease. So these are patients that obviously aren't, it's not just like, oh, here's like the first drug we're going to try, but these are patients where for whatever reason, the treatments that were being used weren't being effective. In terms of timing of the medicines, you can see that Emapalumab was initiated at least with a median time that was relatively early to the diagnosis of HLH or MAS with 13 days. But some patients actually, you can see, got up into the 100-day range, so had a more protractive time between the diagnosis of their MAS and initiation of therapy. And patients received emapalumab for about 2 months. The starting dose, again, you can see the range there. Ranging from basically 1 milligram per kilogram to 6 milligram per kilogram, but importantly with a median of 3.7, right? So the labeling in the US is a starting dose of 1 milligram per kilogram. Maybe the theme for the day will be that, think about higher doses. And indeed, that was what the US physicians were doing right off the bat, starting with the 3 milligrams per kilogram. I will say that, that's the CHOP experience too, right? This really mirrors our practice and what we found to be effective. So we're typically starting at that 3 milligram per kilogram dose. And again, not surprisingly, the maximum dose is around 6 because that's what the labeling says is the max dose. And you can see how much drug people were receiving cumulatively over the course of the 2 months that they were receiving therapy. Okay, so what happened? Well, again, all with a grain of salt, right? Like retrospective data, nothing's enforced. So this is just what physicians are doing after they make a decision, right? But the good news is most people were able to actually wean their glucocorticoids off, right? So again, if you think about what these patients were, these were patients that were refractory, progressive, recurrent, on medicine. So clearly they were using glucocorticoids and the physicians felt like they couldn't get it off prior to initiation. We start this medicine, glucocorticoid dosing was able to come down. The lab values normalize. And I think for me that, this is a busy slide and there's a bunch of numbers. The point that I want to make is for some of these labs, we have to be patient, right? So the ferritin normalizes, but the ferritin normalizes in about a month and a half, right? It just is a really slowly responsive biomarker. The CXCL9 normalizes, but the CXCL9 takes a month to normalize, right? So it's a slow moving biomarker. So mostly what I think you should be looking for is actually the trends, like are things getting better and not like, oh my gosh, is my patient just completely normalized in 3 days? And if they haven't, this is just a failure, right? It's a slow movement of many of these markers. But I think the important thing is the markers you really do care about, like what are their platelets? What is their liver function? Those things that actually represent the organs that we're trying to save with the drug, they tend to move much quicker, right? So you can see that lymphocytes normalized within a week, liver function normalized within 2 weeks, fibrinogen normalized much quicker as well, around 2 weeks. So it's not like you get this instantaneous effect from the emapalumab, but you should start to see trends of things normalizing, and having patients with some of these biomarkers is probably important. This is another way of trying to carve the data up, maybe to make it look a little bit better. So now instead of saying time normalization, it's time to achieving some threshold that we thought meant you're getting better, right? So you can see the numbers that were used for these cutoffs here. They're not necessarily normal values for these biomarkers, but they're values that the study group decided meant that you are becoming normal. And again, you have this half-life to reaching these criteria. But you can see that many patients, in fact, reach these defined criteria for success for all the criteria, right? So another way of carving up the data to basically say that you give the drug, things get better. And then overall survival looked pretty good. There was 1 patient out of 10 that unfortunately did pass away due to disseminated adenovirus. The PI from the site deemed this unrelated to the drug. That's obviously the best we can do. There was a bunch of things that were talked about to make that decision, but it was ultimately decided unrelated to drug. And then since stem cell transplant was brought up as well, 4 of the patients in the cohort were considered for stem cell transplant. 1 of them indeed received the transplant. There were a bunch of reasons why other people did not get transplanted. Point being again, and that's a whole nother story about the role of emapalumab as conditioning for transplant that we're not going to get into. But I think that there is absolutely a role for using that as that bridge for patients that are going for this therapy. So a lot of limitations to the study, right? It's totally retrospective. You get the data that you get. I can't tell you why things happened the way that they happened. It's not randomized controlled data, but it is, I think, reasonably compelling data. that, at least in the real world, use of this medicine does improve patients with MAS secondary to systemic JA. And you get with good overall survival and the ability to reduce glucocorticoids. And I just wanted to quickly mention that, there are, let's say, higher quality data that came from Fabrizio's study with an open label trial of Emapalumab and MAS, where things like were controlled and defined upfront, so you can have a little bit more of a confidence in the data that you're getting, which, again, without spending a lot of time and getting into it, the results are going to look similar, right? Like, you start Emapalumab, the ferritin starts to normalize. You got to be patient, right? Like, the timing here looks a lot like the real world timing. Importantly, the interferon gamma biology is also being normalized by the drug, so drug is hitting target in these patients. And so I think, between the actual clinical trial and the real world data, I think it's reasonable to say that the fundamental biology supports the use of this drug in this disease. We need to admit that we don't have placebo-controlled data for Emapalumab, and then we can have maybe a discussion about like what is actually needed to reach the threshold for comfort in using a medicine for this condition. Do we really need to put people through a placebo-controlled trial or not? But the biology supports it, the real-world data supports it, the phase 2 open-label trial supports it. So I think that this is a conversation that we have to have for these children. And then just to thank all the people that participated in the real HLH study.